sometimes also in a non-traumatic condition where the myocardial infarction or acute coronary syndrome can lead to a ventricular rupture. So whenever there is a cardiac tamponade, we might need to do an urgent e-fast or a fast and try to find out the amount of tamponade, use the same fast to try and mark the point and do a pericardiocentesis. And sometimes if they present in pulseless electrical activity or PEA, we may even need to do an emergency thoracotomy. Tension pneumothorax, on the other hand, would have distended neck veins, absent breath sounds, and a hypotension in these patients with a tracheal deviation. But there is a mnemonic for pneumothorax called the P-thorax, like pleuritic pain, tracheal deviation, hyperresonance. Onset is always sudden, reduced breath sounds, absent fremitus, and an X-ray showing collapse. In a trauma situation, we must always make sure that a tension pneumothorax is a diagnosis made clinically and never depend on a X-ray, which is shown here just for learning purposes. This is how an X-ray looks, but this is mostly a post-mortem X-ray. Do not depend upon an X-ray to diagnose tension pneumothorax. We mentioned about emergency thoracotomy, and there are some indications to do that. Patient needs to present in shock or in fact in pulseless electrical activity. In adults, if there is more than 1.5 liters in the first hour or there is ongoing more than 200 cc per hour in the intercostal drain, that might become an indication for a urgent thoracotomy. And then we also have an algorithm for traumatic cardiac arrest in which we follow the CPR guidelines and simultaneously do a thoracotomy. Neurogenic shock will occur in patients who have spinal cord injury above the T6 level, that is a high cervical or cervical spinal cord injury. And neurogenic shock is a hemodynamic shock where there is a disruption of the sympathetic drive and therefore they are vasodilated. And in these patients, we do not use abundant fluids, but we must start a vasopressor or an ionotropic drug early enough in resuscitating neurogenic shock. So there are some protocols which I can end with, and here we have a protocol which has two arms. One is a hemodynamic management. As we discussed, we try to keep the systolic blood pressure at about 90, but in traumatic brain injury, we need to keep it definitely at systolic of about 120. And on the other side, we have the coagulation management in which we would give the patient 1:1:1 ratio, or we would use the TEG and try to treat the coagulopathy, and also we might use tranexamic acid appropriately after having searched for and controlled the bleeding. And at any level, we need to understand the need for angioembolization in pelvic injuries or the need for a surgeon to go in and try to stop the bleeding. Overview of trauma resuscitation can be at different levels, right from the pre-hospital to the ED to the operation theatre and then the intensive care unit. And there are different levels at which we would do hybrid resuscitation, which is keeping the systolic blood pressure less than 80 for the first hour and then keeping it above 90 in the next few hours. So many things have evolved, but basically sticking to the protocol is what will help us resuscitate trauma victims appropriately.